So these are my notes on poison. After you finish most of the systems in internal medicine, you'll have like 29. I had 29 questions for poison. So these are the notes for those. Well, these two are from first aids, so I'm gonna go over those first. Okay. This one is pretty much covered over here, so I won't. I'll look at that after I'm done with this. Okay. So acetaminophen. Antidote here is in acute doses you give an acetylcysteine. Okay, and it depletes glutathione. In chronic overdose, you give supportive care. Okay. If acetaminophen is taken to commit suicide or something, if the patient arrives at the emergency department within 1 hour or up to 4 hours, we give charcoal. Okay. Research says that charcoal is most beneficial if it's given within 1 hour. However, it's still effective if it's given before 4 hours. Okay, of ingestion. So charcoal is useful in patients presenting within 4 hours of overdose along with an acetylcysteine. Always administer an acetylcysteine in acute doses more than 7.5 gram ingested. Otherwise, get acetaminophen levels and treat if levels more than 150 at 4 hours. Okay, so this is the algorithm basically. Within 4 hours, you give charcoal with N-acetylcysteine. If it's been 4 hours and it's an acute dose, you still give N-acetylcysteine, 7.5 gram ingested, but that's if you know how much ingestion was done. Otherwise, if we get the acetaminophen levels done instead of charcoal, along with N-acetylcysteine, right? And then we treat it if level is more than 150 at 4 hours. Okay. Acid alkali ingestion. Assess ABCs, airway, breathing, and circulation, and remove affected clothing. Upper endoscopy are 6 to 24 hours after endoscopy. Do not try to neutralize acid or base, and do not induce vomiting. This would be like your first response, like instinct to do. If they took acid, give them base, or they took a base, give them acid. But we don't do that, so don't do that. Okay. Activated charcoal is also contraindicated in acid alkali ingestions. Okay. So here, first step is to do APCs, remove clothing. Second is upper endoscopy, 6 to 24 hours after endoscopy. Upper endoscopy, 6 to 24 hours after endoscopy. What? Probably they're saying ingestion. It's probably a typo there. So upper endoscopy 6 to 24 hours after ingestion. Okay. So timing of endoscopy is critical. So these are also called caustic substances. Caustic as in something that is corrosive to your body. Okay. So timing of endoscopy is critical as early endoscopy may fail to characterize the extent of the damage, and late endoscopy is associated with perforation. Neutralization generates copious amount of heat, and vomiting worsens esophageal injury. If the eyes are involved, the eyes should be irrigated and copious amount of water for at least 15 minutes before traveling to the emergency department. Okay. So if it's in the eye, copious amount of water at least 15 minutes before traveling to emergency department. Neutralization generates copious amount of heat, and vomiting worsens as esophageal injury. So that's why we don't neutralize acid or base there. Okay. So first thing you do is ABCs, airway. If it's stuck, we give them intubate them. Breathing, again, same thing. Oxygen probably, and circulation. If there's no circulation, then CPR. next thing you do is endoscopy to gauge how much damage is already done. Okay. For caustic substances, acetylcholinesterases and organophosphates, OP poisoning, and anticholinesterases. Here, antidote is atropine or oxime. In this case, pralidoxime. Okay. It reactivates acetylcholinesterases. Okay. It is found in OP organophosphates or anticholinesterases. They're found in insecticides and sarin nerve gas. Okay. Antimuscarinic, anticholinergic agents. Here, antidote's gonna be your physostigmine. Okay. Most common source is antihistamine medications with anticholinergic adverse effects. Okay. So yeah. Arsenic mercury. Antidote here is Suxamer or dimercaprol. Okay. Arsenic poisoning from contaminated industrial areas or landfills. Acute toxicity is associated with garlic breath and GI symptoms. Chronic toxicity is associated with skin discoloration and peripheral neuropathy. Mercury poisoning from thermometers and old paints. Okay, so garlic breath and GI symptoms, and skin discoloration and peripheral neuropathy from arsenic and mercury poisoning. Here, antidote was Suxamer and dimercaprol. Okay. Beta blockers, it's glucagon. It's also atropine, and this one they tell you. Beta blocker, atropine and saline or saline. Glucagon is positive ionotrope and increases heart rate via a mechanism that bypasses the adrenergic beta receptors. Okay. Barbiturates, phenobarbital. Antidote here is urine alkalinization, dialysis, activated charcoal, and supportive care. No direct antidote is available. For benzodiazepine, we do flumazenil and supportive care, intubation if necessary. Never use flumazenil in the setting of chronic benzodiazepine use. Even if patient is acutely intoxicated, it can produce deadly withdrawal seizures. Okay. Copper, arsenic, lead, gold, penicillamine. Okay. This one to give you a mnemonic for it. Copper, penny, because pennies are made of copper, or they used to be made of copper. Now it's brass, I think. Anyways. Never use flumazenil in the setting of chronic benzodiazepine use. Even if patient is acutely intoxicated, it can produce deadly withdrawal syndromes. Did that. Penicillamine. Penicillamine is chelating agent that sequesters heavy metals. Okay. Cyanide. Cyanide, you give hydroxycobalamin or amyl nitrate. Okay. Or sodium nitrate or sodium thiosulfate. Nitrates induce methemoglobinemia, which binds cyanide. Okay, so it brings out the cyanide from the mitochondria. The electron transport chain can function, and then it's easier to get rid of cyanide if once it's in circulation in the blood, serum. Okay. Then digitalis, digoxin, immune fab. Fragment antigen binding antibodies in symptomatic patients, arrhythmia, altered mental status, acute kidney injury, hyperkalemia. Do not treat hyperkalemia, that is important, or hypocalcemia before giving antidote, because these conditions often correct themselves once the sodium potassium pump is working. Okay, so give the antidote. Antidote is just antibodies against digoxin. Okay. Heparin. Protamine sulfate. Protamine heparin antibodies may induce a clinical syndrome similar to HIT. Okay. heparin-induced thrombotic thrombocytopenia, I think. Iron. Iron has Fe in it. Iron is Fe, so deferroxime, right? Look for radio-opaque tablets on X-ray in a child with hematemesis and metabolic acidosis. Okay. Look for radio-opaque tablets on X-ray in a child with hematemesis and metabolic acidosis. Okay. Lead. Succimer, ethylene, or what was this? EDAT. EDAT. Okay. Ethylene diamine tetraacetic acid, or dimercaprol. Okay. Source of lead include old paint, soil, toys, jewelry, and drinking water. Methanol, ethylene glycol, or antifreeze, fomepizole is the treatment of choice. Ethanol can be used if fomepizole is contraindicated or unavailable. Poisoning from methanol and ethylene glycol results from the active metabolites which are produced by a reaction mediated by alcohol dehydrogenase. Okay, right. So fomepizole and ethanol inhibit the reaction that forms the toxic metabolite. Okay. Cool. And opioids. That reminds me about acetaminophen. If a person is taking that and then it's in their history that they take acetaminophen, but then they come into the emergency department and they have CNS symptoms and all of these stuff, and you're trying to figure out where it's coming from. Is it hyponatremia or all this? First guess should be acetaminophen toxicity, because there's a buildup of the byproducts or its metabolites that will cause CNS symptoms. Okay. Don't go for hyponatremia because it's going to be there, but it's pseudo hyponatremia, or like it's just a lab defect basically. Okay. Opioid, we give naloxone. Okay. I remember in step 1 naloxone was never the answer for anything, but here that's not the case. If you have opioid, give naloxone. It is common to empirically treat patients found unconscious with naloxone. Okay. Salicylates. Here you do urine alkalinization, dialysis, and activated charcoal. But most importantly, that's not given here, is sodium bicarbonate. You give sodium bicarbonate. It's given in step 1. Salicylates, sodium bicarbonate, alkalinization of urine. Okay, so that's the one that causes alkalinization of urine. Cool. But you need to know that. Okay. Symptoms of poisoning include nausea, vomiting, and tinnitus. Tinnitus is important. It's a nice little triad then. TCAs, or tricyclic antidepressants, sodium bicarbonate, diazepam or lorazepam for seizures and agitation. Okay. So you give sodium bicarbonate here as well, or diazepam or lorazepam for seizures and agitation. Monitor closely and only give sodium bicarb if QRS is more than 100 milliseconds or ventricular arrhythmia is present. Okay. Okay. So here they'll tell you that the patient has a history of MDD, bipolar syndrome, and all of these stuff, and then you're trying to figure out if it's lithium toxicity, if it's tricyclic antidepressant, phenytoin, all of these little things, and then this thing comes in clutch when they tell you that QRS is more than 100 milliseconds, or there's ventricular arrhythmia, or there's agitation. What's the next best step? You're going to give sodium bicarbonate. Okay. Tissue plasminogen activator streptokinase. Here we give aminocaproic acid. Overdose may result in hemorrhage and or angioedema. Okay. Warfarin. this should be in your head. Vitamin K. Vitamin K is for long-term reversal. It's never going to be given in an acute setting. You're going to give fresh frozen plasma for immediate reversal in hemorrhaging patient. Another one was PCC, right? Packed cell concentrates. Yep. Warfarin overdose may occur if a patient is concomitantly taking cytochrome P450 inhibitors. Okay, so warfarin overdose may occur if a patient is concomitantly taking cytochrome P450 inhibitors. Okay, let me grab the inhibitors so it's complete here. Give me a sec. So, cytochrome P450 inhibitors are sick phases. Okay, that is sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, acute or alcohol overuse, chloramphenicol, erythromycin, clarithromycin, sulfonamide, ciprofloxacin, omeprazole, imiodarone, ritonavir, and grapefruit juices. Okay. And so that's it. Again, sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, acute alcohol overuse, chloramphenicol, erythromycin, clarithromycin, sulfonamides, ciprofloxacin, omeprazole, imiodarone, ritonavir, and grapefruit. I had a mnemonic for this. Let me see if I can find it. Okay, so my mnemonic wasn't for inhibitors, it's for inducers, but it's here for, completion's sake. So it was St. John grimaced at the carbs and chronic alcohol overuse. Refused more and never again forgot his fen-phen. So St. John for St. John's wort. Grimaced for griseofulvin. At the carbs for carbamazepine and chronic alcohol overuse. Refused for rifampin. More for modafinil. And never for nevirapine. Again forgot his phenytoin and phenobarbital, fen-phen. Okay. So let's go on to signs and symptoms of substance abuse. Okay. Let's see if we missed anything from this first. ACE inhibitors and organophosphates. Atropine is more preferred than pralidoxime. Okay. Arsenic. We did that. We did this. For beta blockers, atropine, glucagon, and saline. Carbon monoxide is 100% O2 or hyperbaric O2. We did this. Dabigatran. Dabigatran we gave idracizumab. Okay. We did digoxin. It was digoxin antibodies or FAB fragments. Direct factor 10A inhibitor or epixaban. We do edixanet alpha. We did that. Methemoglobin. Hemoglobin, we'd give methylene blue and vitamin C, reducing agent. Methotrexate, we give leucovorin, okay. Derivative of folic acid, I think, or folates. Opioids, naloxone, okay. And yeah, sodium bicarbonate for salicylates and TCAs, okay. Signs and symptoms of substance abuse. Depressants. Alcohol. Intoxication is going to show up as disinhibition, emotional liability, slurred speech, ataxia, aggression, blackouts, hallucinations, memory impairment, impaired judgment, stupor, coma, right? Just imagine someone who's drunk times 3,000. Withdrawal, when they don't have it. Within 6 to 24 hours, anxiety, tremor, tachycardia, hypertension. Okay, then 12 to 24 hours, hallucination. 12 to 48 hours, seizures. 48 to 96, that's delirium tremens, fever, agitation, hypertension, hallucinations. Okay. Opioids. Intoxication, it's going to be euphoria leading to apathy. CNS depression. Constipation. Okay. That is important. It's giving you bowel symptoms. Okay. Constipation. Pupillary constriction. respiratory depression, life-threatening and overdose, bradycardia. Okay. I believe between opioid and benzodiazepine, the one that basically differentiates between the two is the GI symptoms found in opioid that are not found in benzodiazepines. Okay. That's how you differentiate between the two, so it's important to pay attention to the history for any GI symptoms. Okay. So constipation, pupillary constriction, respiratory depression, life-threatening in overdose, and bradycardia. Acute reversal of opioid intoxication, we give naloxone. We already went over this. Short-acting, so repeat dosing needed. To prevent relapse, we give naltrexone, longer-acting. Okay. For withdrawal, dysphoria, insomnia, anorexia, myalgias, fever, lacrimation, diaphoresis, dilated pupils, rhinorrhea, piloerection. Okay, piloerection is the is a buzzword for opioid withdrawal. Okay, that's the only one where you'll see it. Okay, basically goosebumps. Tachycardia, nausea, vomiting, stomach cramps, diarrhea, yawning. Okay, yawning. Sorry, I yawned. And now you're gonna yawn too. Go ahead, finish yawning. Okay. Opioid withdrawal is not life-threatening, hurts all over, and does not cause seizure. Okay. It can be treated with buprenorphine or methadone. Okay. So this is where you gotta remember, we give naloxone for intoxication. If someone is going through withdrawal, we give buprenorphine, okay, or methadone. Methadone, they don't give that as an option. It's going to be this, buprenorphine, okay. So again, what does opioid withdrawal look like? They're going to have dysphoria. They're going to have insomnia, anorexia, myalgias, fever. They're going to cry, lacrimation. They're going to sweat, diaphoresis. They're going to have dilated pupils. They're going to have runny nose. They're going to have goosebumps. They're going to have tachycardia, nausea, vomiting, stomach cramps. Again, GI symptoms here as well. Diarrhea, yawning. Okay. Synthetic opioids contains MPTP, synthetic heroin, leading to Parkinson-like disorder and loss of pigmented neurons in the substantia nigra. There's no withdrawal symptoms for these. Okay. This is synthetic heroin, leads to Parkinson-like disorder. So you'll have tremors and all that stuff. Okay, and you will see loss of pigmented neurons. Okay, in substantia nigra. Barbs. How do you differentiate between barbiturate? No, it wasn't differentiating, but like mechanism of action, barbs and bends. Barbs like sit longer, bend like sit more often, right? So that's basically talking about the channels, the chloride channels. The chloride channels stay open for longer time in barbs, and bends it just opens up a lot more often. Okay. Barbiturates, low safety margin, respiratory depression, anxiety, serum, delirium, life-threatening cardiovascular collapse. Okay, in intoxication it was low safety margin, respiratory depression. These are basically something you would imagine for it to do anyways, so it should be easy to remember the intoxication part. The withdrawal, it's going to be the opposite. They're going to be anxious, they might have seizures, delirium, life-threatening cardiovascular collapse. Benzodiazepine, interactions with alcohol, intoxication. So interactions with alcohol, that's why they tell you if you're on benzos, don't drink alcohol. Interactions with alcohol, amnesia, ataxia. Ataxia is the important one here. Okay, they'll walk weird or they can't walk straight. Somnolence, mild respiratory depression, should not be used for insomnia in older adults. Can cause paradoxical agitation even in relatively low doses. Okay. Withdrawal is going to see like rebound anxiety, seizures, tremor, insomnia, hypertension, tachycardia, and death. Okay, so tremors, seizures, insomnia, hypertension. Okay, hypertension is going to be a good presentation for you to figure this out. But again, you don't see any GI symptoms here. Okay. Inhalants like solvents, glue, or fuel. You're going to see tachycardia, nystagmus, tremor, ataxia, slurred speech, unconsciousness followed by drowsiness and headache, perioral rash, common among adolescents. Short duration of action. Long-term use can lead to irreversible CNS damage and polyneuropathy due to vitamin B12 deficiency. Okay. Also, the perioral rash is basically a giveaway for this. Okay, they'll have crusting near the nose or the lip, upper lip. You know, common, and age is going to play a role here as well. So long-term use can lead to irreversible CNS damage and polyneuropathy. Withdrawal of it is going to give you dysphoria, headache, and irritability. Stimulants. Amphetamines. Amphetamines, psychomotor agitation. Intoxication will cause psychomotor agitation, impaired judgment, hypertension, pupillary dilation, tachycardia, fever, diaphoresis, anxiety, angina, euphoria, grandiosity. Okay. Prolonged wakefulness, attention, arrhythmia, delusion, seizures, hallucination, skin excoriation, poor dentations. You'll have the meth mouth. Haloperidol can be given for severe agitations and symptom-targeted medications, for example, antiemetics and NSAIDs. Okay, but haloperidol is the one that you go with in severe agitation. Okay. In withdrawal, you have post-use crash with anxiety, lethargy, headache, stomach cramps. Okay, so GI symptom here in amphetamines, but you have the post-use anxiety as well, and increase in appetite, fatigue, depression, dysphoria, sleep disturbances, and nightmares. Nightmares is also there. Here for opioid, do we have anxiety? We don't have anxiety here. Okay. We have anxiety here. In this. Okay, and lethargy. Cocaine. So intoxication of cocaine. Psychomotor agitation, euphoria, impaired judgment, tachycardia, pupillary dilation, HTN, hypertension, paranoia, hallucinations, cocaine bugs, the feeling of bugs crawling under one's skin, right? Sudden death. Chronic use causes decreased appetite, weight loss, arrhythmia of the nasal turbinates, and septum perforation. ECG changes from ischemia are often seen. Cocaine, chest pain. Treatment here is benzodiazepines or non-selective alpha beta blockers. For example, labetalol. Okay. We don't give beta blockers normally in cocaine intoxication, because then you'll have unopposed alpha action and it will cause vasoconstriction in your nose, and then you have septal perforation and gangrene and all that stuff. Okay. Withdrawal is post-use crash with hypersomnolence. Depression, malaise, increase in appetite, angina, suicidality, and suicidality. I feel like that's a typo. Suicidality. Suicidability. Right? That sounds better. Nightmares. Okay. Caffeine. Intoxication, restlessness, insomnia, diuresis, muscle twitching, arrhythmias, tachycardia, flushed face, psychomotor agitations. You know, look at everyone who's suffering from Starbucks addiction, right? Withdrawal, headache, lethargy, myself included, basically. Withdrawal, headache, lethargy, depression, weight gain, irritability, and craving. Okay. Nicotine, restlessness, insomnia, anxiety, arrhythmias. Okay, all those smokers, basically. And if you stop smoking, if they stop smoking, it's going to be irritability, headache, anxiety, weight gain, craving, bradycardia, difficulty concentrating, and insomnia. Okay. Hallucinations. I mean hallucinogens. Okay. So PCP, the best classic presentation of this is they become violent, right? And aggressive and assaultive. So this is assaultive combative, belligerence, psychosis, violence, impulsiveness, psychomotor agitation, fever, tachycardia, vertical horizontal nystagmus. This is also classic presentation. Hypertension, impaired judgment, ataxia, seizures, delirium. Benzodiazepines or haloperidol can treat severe symptoms, otherwise physicians should offer reassurance. Okay, so benzodiazepine or haloperidol. Where else were we giving haloperidol? And acetaminophen? Amphetamines, right? Okay. Intoxication. So benzodiazepine or haloperidol can treat severe symptoms. Otherwise, physicians should offer reassurance. Gastric lavage can help eliminate the drug. In withdrawal, there's going to be recurrence of intoxication symptoms caused by reabsorption in the GI tract. Sudden onset of severe random violence. LSD. Okay. Not the Bollywood movie Love Sex Logo. This is lysergic acid diethylamide. Okay. Intoxication, marked anxiety or depression, delusion, visual hallucinations, flashbacks, pupillary dilation, impaired judgment, diaphoresis, tachycardia, hypertension, heightened senses. For example, colors become more intense. Okay. Basically, anyone who has taken it, that's how they describe it. Okay. Treatment, supportive counseling, traditional antipsychotics for psychotic symptoms, benzodiazepines for anxiety. There are no symptoms for withdrawal. Marijuana, weed, grass. Okay, joint. Tetrahydrocannabinol or THC, cannabis. Euphoria for intoxication, laughter, slowed sense of time, impaired judgment, social withdrawal, appetite, dry mouth, conjunctival injection, hallucinations, anxiety, paranoia, decreased motivation. Mary Jane. Irritability, anxiety, decreased appetite, insomnia. Marijuana. Bath salts, synthetic catechinones. Okay. Bath salts. There's a. How do I say this without being racist? I'm not going to. I don't want to be cancelled. Stimulant drug that causes agitation, combativeness, delirium, and psychosis that may last for weeks. Not detected on routine urine toxicology screens. Okay, so anxiety, depression, insomnia. Okay. Anxiety, depression, insomnia seen in withdrawal of bath salts. If they're doing bath salts, then stimulant drug that causes agitation, combativeness. Okay, so this is the one where you gotta differentiate it with PCP basically. Okay, delirium, psychosis that may last for weeks, not detected on routine urine toxicology screens. The way you differentiate is with the nystagmus seen in PCP and not in bath salts. Gamma hydroxybutyric acid or GHB. I don't know this one. GHB, hydroxybutyric acid. Is this new street drug? I don't know. Hypotension, bradycardia, respiratory depression, disinhibition, increased libido, and seizures. And what's the withdrawal symptoms? It's irritability, anxiety, tremor, autonomic instability. Okay. MDMA, ecstasy, amphetamine, a derivative with hallucinogenic properties, popular at dance parties or raves. Intoxication will cause hypertension, euphoria, perceptual changes, bruxism. Okay, so bruxism is a classic presentation for ecstasy. Hyperthermia, heat exhaustion, hyponatremia, may have precipitate serotonin syndromes. Withdrawal will show depression, anxiety, and difficulty concentrating. Okay. Moving on to the rest of these. Okay. 40-year-old with 40-year-old drank sodium hydroxide based sodium drain cleaner. Actually, that's not sodium. Drain cleaner 45 minutes ago. The ED department started her on IV, needs normal saline infusion, and infusion is initiated. What's the next best step? Is it activated charcoal in water, gastric decontamination with epicac, intravenous methylprednisone, neutralization of alkaline with dilute acetic acid or solution, or upper gastrointestinal endoscopy. Okay, so drain cleaner is going to be something strong. This is basic, so strong basic solution, also known as alkali substance solution or caustic solution. So for caustic, remember what we do: we check the ABCs, and then after ABCs are identified, then obviously they did the IV normal saline. What's the next best step? We do endoscopy, right? So upper gastrointestinal endoscopy. Caustic ingestion. Clinical features: chemical burn or liquefaction necrosis resulting in laryngeal damage, hoarseness, stridor, esophageal damage, dysphagia, odonophagia, gastric damage, epigastric pain or bleeding. Other things you'll see is like erythema of the pharynx or ulceration seen, right? All of these are also viable here. Management: secure airway, breathing, circulation, ABCs. Decontamination: remove contaminated clothing and visible chemical irrigated exposed skin. Then you do chest x-ray if respiratory symptoms are there. Endoscopy within 24 hours. Okay, there's no within 4 hours, 24, nothing like that. If it's within 24 hours, you do endoscopy. I remember, and up here they said that you got to be careful with the timing of endoscopy, right? Timing of endoscopy is critical, as early endoscopy may fail to characterize the extent of the damage, and late endoscopy is associated with perforation. And you were nah bro, just go with endoscopy within 24 hours. And complications: upper airway compromise, perforation, strictures, stenosis, 2 to 3 weeks, ulcers, and cancers. Okay. This injury can be caused by ingestion of acidic substance, which causes coagulation necrosis. For example, protein denaturation that results in an eschar, thereby preventing further acid penetration and injury. Alkaline substance, for example, many cleaning supplies, which causes liquefactive necrosis, for example, cell membrane dissolution, that often leads to deeper penetration of tissues and therefore more severe injuries. Objective here was caustic alkali ingestion causes immediate esophageal injury with liquefactive necrosis. In stable patients with no evidence of perforation, endoscopy should be performed within the first 24 hours to assess the severity of injury and guide further management. Okay, so clinical features of hypothermia. Mild, it's between 32 to 35 degrees Celsius or 90 to 95 Fahrenheit. Tachycardia, tachypnea, ataxia, dysarthria, increased shivering, right? They're getting cold, but it's not that bad. If their temperature drops to 28 to 32 degrees Celsius or 82 to 90 Fahrenheit for our American friends. bradycardia, lethargy, hypoventilation, decreased shivering, atrial arrhythmias. Okay. Severe, which is less than 28 degrees Celsius for the Canadians, and 82 degree Fahrenheit. Okay. Coma, cardiovascular collapse, ventricular arrhythmias. Okay. So how do you treat these? If it's in general, you warmed 42 degrees Celsius or 107 degree Fahrenheit crystallite, or for hypotension. Okay. Endotracheal intubation and comatose patient. Okay. Rewarming techniques. This is what we do. In mild hypothermia, passive external warming, remove wet clothing, cover with blankets. Moderate hypothermia. Okay. They've been stuck under the snow avalanche and at a ski resort. You find them, moderate hypothermia, 28 to 32. What do? Active external warming. We give them warm blankets, heating pads, and warm baths. Okay, and then we have Leonardo DiCaprio and Titanic and water. He gets picked up. Severe hypothermia. What do? Active internal rewarming. Warmed pleural or peritoneal irrigation. Warmed humidified oxygen. Okay, so warmed pleural or peritoneal irrigation. Warmed humidified oxygen. Active internal rewarming as well. Okay, so active internal rewarming, this is where you give the IV fluids, basically a warmed IV fluid. For moderate, you do external warming. Okay, someone found at the ski resort, right? Under an avalanche, warm blankets, heating pads, warm baths. In mild, you do passive external warming, so remove wet clothing and cover with blankets. After say a 16-year-old got a birthday car and they got into an accident, and then after the accident they recovered her, and then they wrapped her in warm blankets, and then they're like, you shouldn't be driving by yourself. And then rich people problems. Okay, moving on. Laboratory abnormalities in hypothermic patients. Okay, what do you see in hypothermic patients? Abnormalities, you'll see metabolic acidosis. Why? Because of decreased tissue perfusion. You'll see respiratory acidosis. Why? Because of hypoventilation. Azotemia, because of decreased renal perfusion. Hyperkalemia, cellular lysis. Hyperglycemia, loss of insulin effect, less than 30 degrees Celsius, at 30 degrees Celsius or lower, and 86 degrees Fahrenheit or lower. So insulin doesn't work then. Okay, because it is a protein. C-peptide, right? It's a peptide. Peptides stop working in heat. Elevated lipase, cold-induced pancreatitis. Okay, elevated lipase, cold-induced pancreatitis. Okay. Elevated hematocrit, hemoconcentration, coagulopathy, impaired coagulation pathways, leukopenia, thrombocytopenia, splenic sequestration. Okay. Hypoglycemia may be seen in a few patients for reasons that are unclear. Okay. So hypoglycemia may be seen in a few patients for reasons that are unclear. Okay. Endurance athletes are at risk for thermal illness. Probably because they didn't have any food to eat, because they're 16-year-old and they're going through body dysmorphia, right? Okay. Endurance athletes are at risk for thermal illness, both hyper and hypothermia. Mild hypothermia is generally managed with passive rewarming. More severe hypothermia requires aggressive treatment, including active external heated blankets and internal heated peritoneal irrigation, rewarming. Primary therapy for moderate hypothermia includes active external rewarming and warm intravenous fluids. Okay, So here you will also told us to do internal warming as well by giving warm intravenous fluids, whereas for moderate here they didn't hint that. It was only for severe. So here, primary therapy for moderate hypothermia includes active external rewarming and warmed intravenous fluids. Bradycardia associated with hypothermia is often refractory to treatment with atropine and cardiac pacing, but it usually improves with correction of hypothermia. Okay. Slurred speech, unsteady gait, and lethargy are concerning. So ataxia, right? They can't walk straight. Concerning signs of benzodiazepine intoxication. Benzodiazepine overdose can be distinguished from opioid overdose as severe hypoventilation, hypoactive bowel sounds, and pupillary constriction are more likely to be seen with opioid overdose. So differential diagnosis here. Opioid intoxication is likely to include sedation, ataxia, and slurred speech. However, respiratory depression and meiosis, that is pinpoint pupil, are expected as well. Okay, so meiosis, respiratory depression, slurred speech, ataxia, and includes sedation. So here they said ataxia for opioid as well, but it's more related to benzodiazepine and questions. Okay, unsteady gait. Okay, the patient's normal vital signs, for example, respiratory rate 12 per minute, bowel sounds and pupillary reaction reacted to light and size are not expected in opioid overdose. So basically, respiratory rate will also play a major role for differentiating between opioid and benzodiazepine. Okay. Intoxication syndromes and drugs of abuse. So drug, NMDA or PCP, ketamine antagonist. Okay. Clinical features: violent behavior, dissociation, hallucination, amnesia, nystagmus, horizontal or vertical. Remember, this is how we differentiate between PCP and what was the other one? The new drug that I didn't know, GHB, right? GHB. Nope, that's not the one. Bath salts, right? That's how you differentiate between those. Okay. NDMA, ecstasy, euphoria, tachycardia, hypertension, hypothermia, serotonin syndrome, hyponatremia, seizure, and mydriasis. Benzodiazepine, you'll see CNS depression. Okay, these are again intoxication syndromes. CNS depression, normal vital signs, slurred speech, ataxia, coma. Opioid narcotics are oxycodone, euphoria, depression, mental status, depression, respiratory depression, meiosis, and constipation. And apathy was also one of them, right? Arsenic poisoning, garlic breath. Mechanism binds to sulfurhydryl groups, disrupts cellular respiration and gluconeogenesis. Sources are pesticide, insecticide, contaminated water, often from wells, pressure treated wood. Okay, so pressure treated wood is important here. Someone who's dealing with woods or lumberjack, dude's Canadian. Manifestations: acute, garlic breath, vomiting, watery diarrhea, QTC prolongation. Chronic, hyperpigmentation, hyperkeratosis, stock glove neuropathy. So this one's important, the peripheral neuropathy, stock glove. So they'll have symptoms in fingers and feet. So that's a nice little giveaway for arsenic or mercury poisoning. Treatment was dimercaprol, British anti-leucite, or DMSA, meso 2,3-dimercaptosuccinic acid, or succimer. Okay. Good luck remembering that. Exercise associated partial hypotension. Okay, so this is exercise associated partial hypertension. Pathophysiology: cessation of exercise results in sudden decrease in venous return to heart preload. So manifestations are going to be an athlete collapses immediately after cessation of exercise, no loss of consciousness, dizziness or lightheadedness, normal to minimally elevated core temperature. Management is Trendelenburg positioning, that's feet inclined above the head, and oral hydration. Okay. Alright, so exercise associated partial hypotension is thought to occur due to physiologic adaptation and endurance athletes who have significantly higher cardiac output than unconditioned individuals due to hypertrophy and hyperplasia of the left ventricle, that is, athlete's heart. During strenuous exercise, skeletal muscles, particularly in the lower extremities, exert significant pressure on the venous system, which increases venous return to the heart. When an athlete abruptly stops exercising, for example, finishing a marathon, the muscles are no longer exerting pressure and venous return dramatically decreases. The sudden decrease, the suddenness, the sudden decrease in cardiac preload. That was a ode to Arnab Goswami. The suddenness. The sudden decrease in cardiac preload fails to meet increased cardiac demand and results in transient partial hypotension and collapse. This condition may be compounded by inhibition of the barrel reflex and dehydration, which often occur with intense exercise. Unlike many other causes of exercise-associated collapse, for example, exertional heat stroke, sweat-induced hyponatremia, patients with exercise-associated partial hypertension remain alert with normal mental status. Okay, so status. That is a differentiating factor here, okay, between these two and this. Collapse of or inability to walk is typically associated with a sensation of lightheadedness or dizziness. Core temperature may be normal or mildly elevated, as in this patient, from prolonged exercise. Management of exercise-associated partial hypertension is primarily supportive. Patients should be placed in Trendelenburg position, where your legs are above your head, and offered oral hydration. Differential diagnosis: exertional heat stroke presents with elevated core temperature more than 40 degrees Celsius or 104 degrees Fahrenheit, associated with altered mental status or status, for example, confusion, syncope, or seizure. Although this patient's core temperature is mildly elevated, his mental status is normal, making this diagnosis unlikely. Exertional hyponatremia results from excessive fluid intake, weight gain. It presents with confusion, headache, and swollen hands after prolonged heat exposure during an athletic event. A resultant seizure may induce collapse. This patient's normal mental status and consciousness make this diagnosis unlikely. Okay, so that and consciousness. So it happened. Exertional hyponatremia results from excessive fluid intake, weight gain. It presents with confusion, headache, and swollen hands after prolonged heat exposure during an athletic event. A resultant seizure may induce collapse. Okay, cool. So there's that. Ethylene glycol is metabolized by alcohol dehydrogenase to glycolic acid and oxalic acid, which causes anion gap, metabolic acidosis, and organ injury. For example, acute kidney injury. Fomepizole inhibits alcohol dehydrogenase and is the preferred antidote. Sodium bicarbonate and hemodialysis are indicated when there is evidence of acidemia and organ damage. Toxic alcohol ingestion, methanol or ethylene glycol. Typical sources are methanol, windshield wiper fluid, contaminated homemade liquor, ethylene glycol, automotive coolant or antifreeze or brake fluid. Right. Then you have industrial solvents and de-icing solutions may contain either toxic alcohols. Clinical features: early CNS sedation and abbreviation, osmolar gap. Late, it's anion gap metabolic acidosis, compensatory tachypnea, ocular toxicity, methanol, urine oxalate crystals, hypocalcemia, AKI, ethylene glycol. Management: fomepizole inhibits ADHs, uh, is preferred. That's alcohol dehydrogenase inhibitor, is preferred therapy. Ethanol solution competes with alcohol dehydrogenase if fomepizole is unavailable. So if you don't have it, then ethanol, because they both compete for the same dehydrogenase. IV sodium bicarbonate for acidemia, right? So you're alkalining the urine or whatever. pH is less than 7.3. Hemodialysis for severe cases. Okay, so dialysis, we read that in the list as well. For example, acidosis or end organ damage. Carbon monoxide poisoning, epidemiology, smoke inhalation, someone living in a trail park in December. Next morning, they were found confused and unconscious or somnolent state and vomiting or whatever. Okay. So epidemiology, smoking inhalation, defective heating systems, gas motor operating in poorly ventilated areas, manifestations, mild, moderate, headache, confusion, malaise, dizziness, nausea, and severe seizure, syncope, coma, myocardial ischemia, arrhythmias. Diagnosis: arterial blood gas, carboxyhemoglobin levels is what you would do. ECG with or without cardiac enzymes, and treatment is high flow 100% oxygen or intubation hyperbaric oxygen in severe cases. Okay, so we have here high altitude sickness, pathogenesis, reduced inspired oxygen, partial pressure of inspired oxygen at high altitude, more than 2,500 meters or approximately 8,000 feet. Okay. AMS, acute mountain sickness. This is headache, fatigue, nausea. HACE, that's high altitude cerebral edema. Okay, so this is also a complication where you'll have decrease in partial pressure of oxygen, which leads to increase in cerebral blood flow, which causes the cerebral edema. Lethargy, confusion, ataxia. And then you have HAPE, that is high altitude pulmonary edema. Uneven hypoxic vasoconstriction, dyspnea, cough with or without hemoptysis, and respiratory distress. All of these you probably already know, so it should be easy to remember these. Treatment: supplemental oxygen, acetazolamide for as acute mountain sickness, right? That's important, but another important one that you will most likely forget is dexamethasone for HACE, high altitude cerebral edema. Okay, so you want to give dexamethasone if they give you an option what to give this person who is in confused, lethargic, and difficulty in walking. Don't give him furosemide or acetazolamide or whatever other options they have. Give dexamethasone. Okay. Another thing you can do is descend to lower altitude, definitive treatment for HAI, high altitude illness. Expected oxygen level at altitude. So we have altitude here. As the altitude increases, the saturation and partial pressure of oxygen decreases. Okay, so saturation decreases slower than partial pressure of oxygen. Okay. This patient's initial symptoms, that is gradual headache, sleep difficulty, dyspnea with exertion, are likely due to acute mountain sickness. The development of drowsiness suggests progression to high altitude cerebral edema, HACE. A rare life-threatening emergency, high altitude illness results from abrupt ascent to high altitude without acclimatization. AMS and HACE share the same pathophysiology, which is believed to involve hypoxia-induced, for example, low PaO2, cerebral vasodilation causing capillary leakage, and eventually cerebral edema. Many patients whose condition progresses to HACE also have evidence of high altitude pulmonary edema. AMS occurs within the first 24 hours of arrival at high altitude and involve relatively mild symptoms of fatigue, headache, and disturbed sleep. It is common and generally resolves within a few days with or without treatment, for example, oxygen acetazolamide. Haze can be viewed as an end-stage AMS. Okay, so that haze again, that is high altitude cerebral edema. It can be viewed as end-stage acute mountain symptom. Generally occurring 12 hours to 3 days after AMS onset. The development of encephalopathic symptoms, that is drowsiness, confusion, ataxia, signals this progression. If left untreated, coma and death due to brain herniation can occur within 24 hours. Haze is diagnosed clinically. Treatment is aided by dexamethasone. Okay, so look out for drowsiness, confusion, ataxia when they came from hiking on a mountain or a ski trip from at Colorado or something, right? Look out for that. It's probably a sign of cerebral edema. You give dexamethasone, which can decrease cerebral swelling and is administered at the first sign of symptom. Definitive management requires immediate descent to lower altitude. Opioid withdrawal. Time course 4 to 48 hours after opioid cessation, immediately after opioid antagonist. Life-threatening. Okay. Clinical features: gastrointestinal, nausea, vomiting, cramping, diarrhea, increased bowel sounds, right? GI symptoms. Cardiac, increase in pulse, increase in blood pressure, diaphoresis. Psychologic, insomnia, yawning, dysphoric mood. Others, myalgia, arthralgia, mydriasis, lacrimation, rhinorrhea, piloerection. Diagnosis: history and examination alone. Clinical diagnosis: management, opioid agonist, methadone or buprenorphine. Okay, so here for alcohol withdrawal, we are giving methadone or buprenorphine. Okay, don't pick naloxone for this. That is for intoxication, not this. So what do we give? We give opioid agonist, which is methadone or buprenorphine for withdrawal symptoms of opioid. Non-opioid, we give clonidipine or adjunctive medications like antiemetics, antidiarrheal, or benzodiazepine. Intravenous naloxone is a potent opioid antagonist used for a patient with opioid intoxication. It can induce rapid withdrawal and should not be used in an individual who already has withdrawal symptoms because it may worsen them acutely. Okay. The classic triad of acute opioid intoxication is altered mental status, respiratory depression, and meiosis. When opioid intoxication is suspected, naloxone or opioid receptor antagonist should be immediately administered. So this is where we give naloxone. Clinical features of acute opioid intoxication: risk factors are substance use disorder, chronic opioid use, hospitalization, especially post-operative, and hepatic or renal insufficiency will all cause opioid intoxication. Okay. Clinical features are somnolence, acute mountain sickness, right? No, altered mental status, sorry. Why are they using the same abbreviations for two different things? Altered mental status. Okay, so somnolence, altered mental status, pinpoint pupils, meiosis, shallow breathing, and decreased respiratory rate, bradycardia, hypothermia, decreased bowel sounds, and respiratory acidosis on ABG analysis. Management here is what you should know by heart now. Naloxone may need repeated administration. Airway management and ventilation, and exclude other altered mental status causes like hypoglycemia. Okay. This patient with altered mental status is on morphine therapy and has concurrent renal insufficiency, possibly due to progressive multiple myeloma. This presentation raises suspicion for opioid intoxication. Morphine is first metabolized in the liver, producing active metabolites that is retaining mu opioid agonist activities, such as morphine 6-glucuronide, that are renally excreted. Okay. So metabolites for morphine are renally excreted. So someone who has renal insufficiency will get accumulation of these metabolites causing symptoms. Okay. In patients with impaired kidney function, such as this patient, accumulation of these metabolites can lead to altered mental status, sedation, and respiratory depression. Several other opioids, for example, codeine or meperidine, also have active metabolites that are renally excreted and should be avoided in patients with renal insufficiency. Opioids that have inactive metabolites, for example, fentanyl, or that are not dependent on excretion by the kidney, like methadone, are preferred. Okay, so here's one place where methadone might be an option. Okay. Opioids that have inactive metabolites or that are okay. So something that won't cause symptoms even if there is a buildup of it. Okay. So opioid medication in patients with impaired kidney function recommended are fentanyl, hydromorphone, methadone, or buprenorphine. Okay. Avoid. What are you going to avoid? Morphine, meperidine, codeine, or tramadol, which is a partial opioid. Okay. Where do we give buprenorphine? We give it here. Here, right, in the withdrawal, right? Opioid withdrawal, methadone or buprenorphine. Okay, and certain opioids like morphine have active metabolites that are eliminated by the kidneys and can cause opioid toxicity in patients with renal insufficiency. Opioids that have inactive metabolites, for example, fentanyl, or are not dependent on renal elimination, like methadone, are preferred. Differential diagnosis: severe hypothermia, that is less than 120 to 125 milliequal per liter. Right now, normal is like 136 to 145 levels. Can cause altered mental status and weakness, but this patient's moderate hyponatremia is unlikely to cause such symptoms. Multiple myeloma can cause pseudo hyponatremia due to displacement of water by high globulin content in the blood, but this is a laboratory artifact, not true hyponatremia, and would not cause symptoms. So this is what I was talking about earlier when I said it's a lab defect. Bites from imported fire ants. Okay, so a kid walking in the grass stepped on an anthill, and now he has bites from imported fire ants. Okay, so it causes sterile pustules. Okay, so it's sterile. The venom in fire ants are antimicrobial, so there are not that many chances of infection. So don't pick an option where it's talking about antimicrobial, antibiotic, topical stuff, or anything like that. Okay. So sterile pustules that should be left intact to prevent secondary infections. So don't open the pustules, even though they're giving the kid a hard time from walking. Pustules and small local reactions require no treatment. Large local reactions can be treated successfully with antihistamines and topical steroids. Okay, so that's important to remember. Okay, differential diagnosis: unroofing the sterile pustules caused by stings from imported fire ants can lead to a secondary infection. Topical antimicrobial cream is not indicated unless an infection is present, unlikely in less than 24 hours as in this case. Infections are uncommon in part because imported fire ant venom contains antimicrobial properties. Large local reactions: epidemiology and pathophysiology, often due to bites from Hymenoptera species, for example, bees, ants, and wasps. Exaggerated immunoglobulin E-mediated local allergic response, approximately 10% of stung individuals, associated with possible increased risk for future systemic reactions. Manifestations: significant, approximately 10% or more, localized swelling, erythema, and warmth. Swelling and erythema contagious with site of the sting. develop within 24 hours, peak within 24 to 48 hours, resolves in 5 to 10 days. Treatment: cold compresses, oral and or topical steroids, antihistamines, anti-inflammatory medications. Okay. We have a 17-year-old with abdopain, vomiting, and blurred vision. With RESP at 22, ophthalmoscopy reveals optic disc hyperemia and abdotenderness. Okay, so abdotenderness is there and blurry vision. Okay. We have sodium at 136, bicarb is 7, and BUN is 30, and plasma lactate is 2. Which of the following is causing this? Is it aspirin overdose, diabetic ketoacidosis? Okay, so blood glucose was 80, so that's not it. Ethylene glycol toxicity, methanol ingestion, or toluene inhalation, glue sniffing. So in this case, it was methanol toxicity. Okay. So methanol ingestion. How did we get there? We did the serum anion gap. Okay, and then it was high. Okay. Serum osmolar gap measured to calculate it, and then we got that high as well. So it was either methanol or ethylene glycol. Okay. But then creatine was normal, so then we went with methanol. Okay, I guess I will explain it here. But features of commonly ingested alcohols: substance typically ingested, major metabolite, increased osmolar gap, anion gap increase, and other clinical features. For ethanol, it was beer, wine, liquor. Okay, major metabolite is acetaldehyde, minor toxicity, osmolar gap is increased, and anion gap is also increased if ketosis, and confusion is there. Okay, methanol, windshield wiper fluid, homemade liquor. Formic acid, major toxicity. There is osmolar gap and anion gap. Other clinical features are confusion, vision, and vision deficits. Ethylene glycol, antifreeze, glycolic, and oxalic acid are the metabolites. There is osmolar gap and anion gap increase. You'll have confusion, calcium oxalate crystals, AKI, flank pain. Isopropyl alcohol, rubbing alcohol, hand sanitizer. Metabolite here is acetone, minor toxicity. There is osmolar gap but not anion gap here, and clinical feature is confusion. Okay, so evaluation of metabolic acidosis, serum anion gap, that's sodium minus chloride plus bicarb. Okay, and that you can just take a look. After that, you do serum osmolar gap. You calculate it and then see what the one you get is. There was something like that. I think I covered in the pulmonary section of the videos. Okay, you can take a look there and this. So methanol toxicity is characterized by encephalopathy, abdominal pain, vomiting, and high anion gap metabolic acidosis. Optic neuritis is a common complication that distinguishes methanol ingestion from other toxic alcohol ingestions. For example, ethylene glycol. Differential diagnosis here is ethylene glycol and methanol toxicity both causes edema and encephalopathy. However, ethylene glycol ingestion does not cause optic neuritis. Okay, here we had the finding that showed optic disc hyperemia, right? Kidney dysfunction due to calcium oxalate stone formation would more likely be present. This patient's elevated BUN is due to dehydration, volume depletion from vomiting. Okay. Exertional heat stroke. Risk factors: strenuous activity during hot and humid weather, dehydration, poor acclimatization, lack of physical fitness, obesity, medications, anticholinergics, antihistamines, phenothiazines, tricyclics, and antipsychotics. Okay, all of these, remember, antipsychotics, tricyclics, these can cause heat strokes. Okay, antihistamines, anticholinergics are easier to remember. Phenothiazines. Okay, it's not just lack of physical fitness or obesity or dehydration or poor acclimatization or even strenuous activity during hot or humid weather. These are not the only ones that causes exertional heat stroke. Okay, you remember medications can do that too. Clinical manifestations: core temperature more than 40 degrees Celsius or 104 degrees Fahrenheit with CNS dysfunction, for example, altered mental status and seizure, organ or tissue damage, renal or hepatic failure, disseminated intravascular coagulation, acute respiratory distress syndrome. Management: rapid cooling, ice water immersion preferred. Can consider high flow cold water dowsing, ice wet towel, rotation, evaporative cooling. Okay, that's rapid cooling. Another is fluid resuscitation, that's electrolyte correction, then management of end organ complications, and no role of antipyretic therapy. Okay. Exertional heat stroke is characterized by temperature more than 40 degrees Celsius, 104 degrees Fahrenheit, and CNS dysfunction, for example, altered mental status, seizure. First line treatment is rapid cooling with ice water immersion. And differential diagnosis here was oral hydration and Trendelenburg positioning are appropriate for exercise associated collapse, which occurs in conditioned athletes immediately after cessation of exercise due to sudden decrease in cardiac preload. Although syncope can occur, prolonged altered mental status and severe hypothermia are unexpected. Okay, and exercise associated collapse. Here there was prolonged altered mental status. Then you have a dentraline. If you don't remember, it is used in neuroleptic malignant syndrome, which can develop in patients taking antipsychotic agents, for example, quetiapine. Okay, quetiapine. Is that cutie pine? Okay. And malignant hyperthermia, which occurs in genetically susceptible individuals given inhalation as anesthetics. Both can cause hyperthermia, tachycardia, and altered mental status. However, muscle rigidity is typically present. In addition, NMS symptoms generally develop over several days, not 2 hours, and malignant hyperthermia occurs within minutes of anesthesia administration, not months later. Okay. Clinical feature of marijuana, weed, marijuana, Mary Jane. Okay. Grass. Intoxication include increased appetite, tachycardia, tachypnea, dry mouth, and conjunctival injection. Marijuana use slows reaction time, impairs attention, concentration, and coordination, and can increase the risk of motor vehicle collision. Okay. Characteristic of, so that goes back to, the Sweet 16 with new car. Got into a crash. Now the paramedics have her sitting on the curbside with blankets around it, right, to reduce the hypothermia from shock. And the eyes are red. With increased appetite, they have the munchies, so she's eating brownie cookies from Domino's. Now I'm craving marble cookies from Domino's. Anyways, moving on. Characteristics of acute and chronic salicylate toxicity: individual vomiting, tinnitus, pulmonary edema, hyperthermia, tachypnea, and an onion. And an anion gap metabolic acidosis. Now I'm thinking of Domino's pizza now with onions on top. Oh, okay. And an anion gap metabolic acidosis. Hemodialysis is indicated in patients with altered mental status, pulmonary edema, renal failure, and persistent acidosis. Okay. Management of salicylate toxicity. It's what we read. You don't need to pay attention to this. If you're zoned out, it's fine. Stay zoned out. The thing is, if they're taking salicylates, in the history, they're going to ask you, what do you give? You give sodium bicarb, right? So I'll just jump to that. You can give activated charcoal, okay, bind salicylate in gastrointestinal tract and decrease systemic absorption, given within 2 hours of acute ingestion, unlikely helpful in chronic ingestion. Avoid in confused or obtunded patients, risk of aspiration. Intravenous sodium bicarbonate alkalizes urine and serum, enhances salicylate excretion, requires a large volume of fluid to be administered. Indications of hemodialysis: inability to tolerate large volume of sodium bicarbonate, pulmonary edema, acute or chronic renal failure, persistent. Okay, so if they can't take sodium bicarbonate or they have pulmonary edema or chronic renal failure, we want to go for hemodialysis. Okay, persistent acidosis or worsening clinical condition despite sodium bicarbonate therapy, or severe ingestion causing shock, seizure, CNS dysfunction, cerebral edema. In all of these cases, we will opt for hemodialysis. Okay. OP poisoning. I feel like we already went over this. But anyways, I'm just going to go over I'll just go over the whole thing. Organophosphates are acetylcholinesterase inhibitors that are commonly used as agriculture pesticides. Toxicity is characterized by signs of cholinergic axis, for example, meiosis, bronchospasm, muscle vasculation, weakness, diarrhea, vomiting, lacrimation. First-line therapy is atropine, a competitive inhibitor of acetylcholine at muscarinic receptors, and another one is oximes, right? So they basically, what do? They break down the acetylcholine. They replenish the acetylcholinesterases, so cholinesterases can break down acetylcholine as well. So it works that way as well. Okay, so organophosphate poisoning, common exposure, pesticide, farmer field workers, pediatric ingestion, suicide attempt, nerve agents like multiple patients present at a shopping mall, and everyone started getting these symptoms together, right? They had meiosis, bronchospasm, lacrimation, salivation, drooling from the faces, right? If you see a bunch of people just starting to drool, chances are there's a OP poisoning happening, right? So muscarinic, again, dumbbell for diarrhea, diaphoresis, urination, meiosis, bronchospasm, bradycardia. Okay, emesis, lacrimation, salivation. Nicotinic, muscle weakness, paralysis, fasciculations. Management here is remove patient's clothing, irrigate skin. Okay, when it's a bunch of people this happens to, I don't know if you have seen like CSI or something. They have, or even in Dr. House, House MD, they had like this episode where they put up a tent with white plastic, polythene or whatever, and then they had like showers, and people in hazmats were basically watering them down to clean them of whatever toxic gas it was flowing in that area. Okay, so management, remove patient's clothes, irrigate skin. Atropine reverses muscarinic symptoms. Pralidoxime reverses nicotinic and muscarinic symptoms. Administer after atropine. Okay, so always give atropine first and then pralidoxime. So December in mobile home, right? Chances are carbon monoxide poisoning. Okay, we already went over this whole thing, so I'm just gonna bypass that. Carbon monoxide poisoning can occur due to faulty indoor heating systems during the winter months. Both oxygen delivery and usage are disrupted, causing clinical manifestations of cerebral hypoxia. For example, headache, confusion, seizure, coma, death. Diagnosis is made by co-oximetry of oximetry of arterial blood gas showing an elevated carboxyhemoglobin levels, and treatment is with 100% oxygen. For patients who present with 4 hours after a single potentially toxic ingestion of acetaminophen, The first step in management is gastric decontamination with activated charcoal, and acetaminophen level should then be obtained 4 hours post ingestion and plotted on the Rummock-Matthew nomogram, which is used to guide treatment with an acetylcysteine. Okay. So this is initial management of acute acetaminophen overdose algorithm. Time since ingestion. If it's less than 4 hours, we administer activated charcoal. Okay. Then we continue to check. If it's between 4 to 24 hours, we go down, and then it's similar for both of them. So if it's less than 4, we give activated charcoal, but we still continue to do the rest of the thing. If it's 4 to 24 hours, charcoal is not really effective, so we just go straight to the next step, which is check acetaminophen levels more than 4 hours, 4 or more hours after post ingestion. Consider empiric and acetylcysteine for any evidence of liver injury, for example, elevated ALT, AST, right upper quadrant tenderness. If it's 8 hours or more since ingestion, or acetaminophen level not available until for 8 hours or more post ingestion, then we also consider empiric and acetylcysteine. Okay. If acetaminophen level are available to us, then plot level on Rummock-Matthew nomogram and administer an acetylcysteine if level is above the treatment line. Okay. So here we have the Rummock graph, Rummock-Matthew nomogram. On this side, on the y-axis, it's acetaminophen plasma concentration. On the x-axis, it's hours post-ingestion. Okay. And Rummock-Matthew line is like plotted as that. Okay. So this is the treatment line. Okay. So they said if plot on this, administer NEC if level is above treatment line. Okay. So, see, after 4 hours, the levels of acetaminophen is 200, right? So if it's here, we give an acetylcysteine. Okay. So after 24 hours, it's the level is at 3. We don't give an acetylcysteine. We just let the body do its thing. Basically that. Straightforward. Like that. Okay. Cool. Major depressive disorder. Okay, so clinical features and management of tricyclic antidepressant overdose. Okay, so clinical features: CNS, mental status change, drowsiness, delirium, coma, seizures, respiratory depression. Okay, a lot of these symptoms overlap with like substance abuse as well. But that's when you gotta look at the history. They will give you a history of someone with MDD or seizure. Sometimes they tell you that they have polysubstance abuse history as well, in which case you gotta pay attention to the symptoms. Okay. Cardiovascular, sinus tachycardia, hypotension, prolonged PR, QRS, QT intervals, arrhythmias, for example, ventricular tachycardia, fibrillation, anticholinergic. Okay. TCAs cause anticholinergic symptoms: dry mouth, blurred vision, dilated pupils. Not many things cause dilated pupils, so that's a plus for us here. Urinary retention, flushing, hyperthermias. Okay. Management: supportive care and therapy. Supplemental oxygen intubation, intravenous fluid, activated charcoal for patients within 2 hours of ingestion unless ilia is present. Intravenous sodium bicarbonate for QRS, interval widening, or ventricular arrhythmia. That's the one we read about up there. And activated charcoal. Okay. So tricyclic antidepressant overdose can present with CNS, cardiac, and anticholinergic findings. Sodium bicarbonate is used to treat cardiac toxicity. Okay, so remember that, which is characterized by prolonged QRS duration, more than 100 milliseconds, and ventricular arrhythmia, that is, for example, ventricular tachycardia or ventricular fibrillation. Okay. All right. frostbites. Differential diagnosis. Intravenous infusion of warm fluids is indicated in the management of systemic hypothermia but is not effective in frostbite injuries. So if you have frostbite injuries, you're not going to do intravenous infusion of warm fluids. Okay. Thrombolytic therapy. For example, tissue plasminogen activators can be considered for deep frostbite injury that is expected to require extensive amputation, although the evidence is limited. It is not advised in limited distal frostbite. Severe frostbite injuries may require multiple debridement procedures, but initial assessment may overestimate the extent of tissue damage. Okay, so severe frostbite injuries may require multiple debridement procedures, but initial assessment may overestimate the extent of tissue damage. Debridement is not indicated until the tissue is rewarmed and an accurate survey of devitalized tissue can be performed. Okay, so frostbite. Clinical features: superficial pallor and anesthesia, blistering, eschar formation, deep tissue necrosis, and mummification. Management is rapid rewarming and water bath. Okay, so microwave some water and put it in at 37 to 39 degrees Celsius, 98.6 to 102.2 degree Fahrenheit. Okay. Analgesia and wound care, angiography and technetium 99M scan to assess for thrombosis if rewarming is unsuccessful. I remember we do that for Meckel's diverticulum as well to view gastric epithelium in intestine, I think, right. Thrombolysis is in severe life-threatening cases. Initial management of frostbite is based on rapid rewarming of affected tissues in a 37 to 39 degrees Celsius, 98.6 to 102 Fahrenheit. Water bath, hot air rewarming is not recommended, and rewarming should not be attempted if there is a possibility of refreezing before definitive care can be provided. Okay. Salicylate toxicity, already did this. So treatment: activated charcoal, alert patient within 2 hours of ingestion. Intravenous sodium bicarbonate enhances salicylate excretion and hemodialysis. Severe ingestion: pulmonary edema, renal failure. Okay. Urinary retention in a case. So out of the option, it was diphenhydramine. Okay. There was anticholinergic toxicity. Okay. So symptoms are hot as hair. So basically dumbbells opposite. Okay, so hot as air, dry as bone, red as beet, blind as bat, mad as hatter, full as flask, and fast as fiddle. Okay, mechanism of these are: decreased sweating leads to decreased heat dissipation, decreased glandular secretion and smooth muscle contraction, superficial vasodilation from increased body heat, paralysis of ciliary muscle and iris sphincter, permeates blood-brain barrier and affects CNS pathway, decreased intestinal smooth muscle contraction, decreased detrusor contraction, and decreased internal urethral sphincter relaxation, and decreased vagal tone at the sinoatrial node, causing tachycardia. Okay. Common agents with anticholinergic properties: antihistamines, that's diphenhydramine and cyproheptadine. Okay. In psychotropics, we have first generation, which are chlorpromazine and haloperidol. Second generation, clozapine. Tricyclic antidepressants, amitriptyline and clomipramine. Amitriptyline, one is this for depression, and another use for amitriptyline is also used for neuropathic pain and radiation. Okay. Remember that from musculoskeletal section. Okay. Anti-Parkinson, benztropine and trihexyphenidyl. Okay. Antimuscarinic ones. These are ipratropium, bronchodilator, oxybutynin, darifenexine, overactive bladder. Okay, so OB for overactive bladder and OB for oxybutynin. Okay. Dicyclomine, hyoscamine, antispasmodics, and scopolamine, antiemetic. Mydriatic, atropine, and cyclophenolate, and plant-based are jimsonweed, muscarinic mushroom species, and nightshade species. Anticholinergic toxicities can cause confusion, mydriasis, for example, blurry vision, hyperthermia, dry mucous membranes, and urinary retention due to widespread competitive blockade of muscarinic acetylcholine receptors. This can occur from overdose of common medications, for example, diphenhydramine, that have anticholinergic properties. What's the antidote we give for this? Do you guys remember? Acetylcholine. Which one was it? It was given here. Atropine and pralidoxine. Okay, it reactivates acetylcholinesterase, and it's found in insecticide and serine nerve gas. Cool. Okay. So done with that. So there's a mall. Crowd got rapid onset of shortness of breath. Smelled faint, fruity odor prior to symptoms, and drooling and diaphoretic. Already talked about this. Confirmed diagnosis is you do red blood cell acetylcholinesterase activity test. Okay. Organophosphate inhibits cholinesterases in both muscarinic and nicotinic cholinergic synapses, leading to increased visceral smooth muscle tone and glandular secretion. Mnemonic is dumbbells, as well as muscle fasciculation, weakness, and paralysis. Organophosphate poisoning can be confirmed with the measurement of red blood cell acetylcholinesterase activity. Okay, and we talked about the antidote for that. In patients with clinical signs of opioid intoxication, for example, altered mental status, respiratory depression, hypotension, hypothermia, decreased bowel sounds, naloxone, should be administered immediately. Early administration decreases the need for invasive intervention, for example, intubation. And that's it. We're done. See you in the next one.